With the increased pressure from government, insurance companies, medical boards, and healthcare systems to decrease the total daily dose of opioids, we will begin to see a rise in the characteristic symptoms identifying an opioid use disorder. Many of the patients we have been treating for years with chronic pain are opioid use disorder patients with a pain disguise. We can expect this pressure to maintain patients on a lower dose will continue into the foreseeable future, and we will need to be prepared as to how to help these patients. Opioid use disorder is essentially a narcotic addiction to a prescription dose of opioids. These unfortunate patients have suffered the same brain neurological changes that occur in the brain of a heroin addict, but it is developed in an attempt to control pain and not seek a euphoric drug state. We live in a pill-embracing culture, a culture that has led to unrealistic expectations as to what these pills can safely do for you. It used to be that giving a higher and higher dose of narcotics was considered good medical practice when applied to patients in pain, but now it is considered poor medical practice to prescribe opioids. This has led to frustration and confusion and a considerable potential for the development of opioid use disorder. The prevalence of opioid use disorder among patients receiving more than 15 morphine equivalents per day has been reported to be as high as 41%. We have all been working hard in the midst of significant resistance to wean our patients down from the opioid doses they have been used to taking. I believe that because we have been working hard as a medical community to wean patients from opioids, the percentage remaining who have opioid use disorder is considerably higher than the reported 41%. With some patients, that reduction of dose has been very successful, and they have tolerated the 10% reduction per month without a problem. With many others, however, it has been a battle that leaves you as the medical provider bruised and burned out. The battle exists because we are treating the wrong diagnosis. Treating an opioid use disorder as if it is pain will only lead to conflict and turmoil. You know the frustration, you know the feeling. Just take a look at the list of patients you're about to see today. So if we look at the current group of chronic opioid using patients, how do we arrive at the correct diagnosis? Some patients will have legitimate pain and need long-term treatment, but others will need a more appropriate treatment for an opioid use disorder. How do we determine who has an opioid use disorder? This field is very confusing, and just trusting your gut will often provide unreliable and inaccurate information. Let's take a look at some of the specific characteristics of the opioid use disorder and how it presents. Your patient will show signs of higher resistance when there's an attempt to reduce them from the doses they have been used to taking in the past. The higher the opioid dose that they are on, the greater likelihood that you are going to be dealing with an opioid use disorder, especially if their daily dose is greater than 90 morphine equivalents. You'll also see that increasing doses has resulted in little to no improvement in their symptoms. They have a history of missed appointments, showing up late for appointments, missed work, failure to fulfill obligations. They require early refills for lost or stolen prescriptions. You observe that there's a significant life interference in your patient. The physical pathology does not match the degree of life interference. This is a sign of pleasure being lost in all areas of life except the opioid use. This is a clear indication that opioid use disorder is present. There is often an increased evidence of cravings, the need for an extra bedtime dose or a dose in the middle of the night. They may have a previous diagnosis or evidence of another addiction to things such as food, alcohol, gambling, marijuana, nicotine, or microprocessor use. You will see a greater prevalence of opioid use disorder with patients who have been diagnosed with a psychiatric disorder, especially in patients with post-traumatic stress disorder. It is also more common with diagnoses like fibromyalgia or irritable bowel syndrome. So now that you recognize the problem, we get to the difficult part as to how do we deal with it. Now that you have identified your patient as having opioid use disorder, how are you to deal with this problem? First of all, we will need to understand the disease we are dealing with, not the pain diagnosis disease, but the opioid use disorder disease. We will need to understand the specific issues with this patient, and then you'll have to understand the issues of treating a disease that the patient does not believe they have. First of all, the uniqueness of the disease. So what is this disease of opioid use disorder? The opioids, although not as strong as heroin, have caused the same type of brain structural and functional changes. For a more detailed review of this, please see the video titled The Disease of Addiction on the Fractured Resilience website. This patient's brain is addicted to prescription opioids. The problem is that when they start to wean from the opioids, they begin to experience a physical pain much worse than the pain caused by the disease for which the opioids were originally prescribed. Do not forget you are dealing with a brain disease, meaning your best intellectual reasoning will only fall on deaf ears. You are all very good reasoners and good patient motivators, but in this case, reason alone will not work. This is the primary reason these visits are exhausting. You are trying to reason with a diseased brain. There's some very important aspects about this patient that we also need to understand. This patient is what we would call a rebellious pre-contemplator who is heavily invested in their. On the stages of change scale, these patients are really entrenched pre-contemplators. They see no need for the change in dose. They've been given a medically justifiable reason to be on opioids. These patients are what is called rebellious pre-contemplators. They are afraid of losing control over their lives and have a large investment in their disease. Your challenge is to help them shift this energy into making a more positive choice for themselves, rather than rebelling against what they perceived as a rigid pressure on your part. I'm sure you have all seen patients who present like this when you want to discuss reducing their pain medications. The goal is to use your best motivational interviewing skills to shift the pre-contemplator to the stage of contemplation. How do you do that? If you do not have trusting rapport with your patient, it may not be possible to make this shift. You need a foundation of trust. Then you can gradually move towards contemplation. Compassion at this point means being available to your patient and listening to your patient. This is a steep path for both you and your patient. Make sure that you teach just a little at a time. This will require multiple visits over many months. Be patient. This will take a long time. Forget to provide options. The options of remaining on high-dose opioids will not be one of your options, but there are many other options you can provide to your patient as you walk this path together. Some of the options may be physical therapy, referral to pain specialist or addiction specialist, buprenorphine, methadone clinic, weaning of one drug at a time, perhaps holidays during which time the weaning does not occur. This will require frequent office visits. It may even require weekly office visits for a period of time. Care provided to these patients needs to be compassionate with boundaries. You might not be able to reason, but you can set clear limits without getting distracted by the pain. Here are some of the boundaries worth considering. It is also important that you have a pain contract signed by your patient that will cover the boundaries that you put in place. It is best to let the patient know that this will require frequent office visits for a while, and that you recognize it will be difficult for them, but that you are their ally on this path. Random pill counts will be necessary with some patients. You need to develop an office policy as to how this can be done without being a major burden to your office staff. There should be no allowance for early refills. If early refills are requested, then shortening the length of the next prescription will be required. You may end up having to prescribe medications weekly to stay on track. There should be no refills for lost or stolen prescriptions. You'll need a policy regarding marijuana and alcohol use, and this policy should be consistent with your medical community. To keep track of compliance, you'll need to do frequent toxicology testing. It is best to limit refills to face-to-face contact with the patient, and not at the request of a phone call or a fax. You'll need a policy and a plan regarding benzodiazepines. The safest plan may be to reduce the benzodiazepines first and then reduce the opioids. Whatever your plan, it is important that you develop a clinic and medical community policy about benzodiazepines and opioids. Do not take the emotional hostility personally. Be compassionate and stick to the boundaries. This is a very difficult situation to deal with, and as a medical community, we need to stand together in developing and carrying out a plan. Not only is your patient a rebellious pre-contemplator, but they have a huge investment in their medical condition and the medications that they receive. We should really pause for a moment to consider what this patient has invested in their condition. A patient with an opioid use disorder often becomes their disease. It is now their arthritis, their back pain, their abdominal pain, their severe pain. They have become their disease. And now you are telling them that they have a completely different problem. In a way, they are seeing you as threatening their identity. These patients will often define themselves as their disease and as a victim of their. We need to consider how many hours this patient in front of us has spent on their disease. How much time getting to office visits, waiting in a crowded waiting room, waiting for tests, waiting for test results to come back, waiting at the pharmacy. The time investment is huge. The money investment is also huge. The cost involved in office visits, prescriptions, and time away from work will definitely take a major financial. They are also viewed by others, particularly family members and associates, as the one with the disease. Now that we have a little better understanding of the disease of opioid use disorder and the rebellious pre-contemplative patient, there are a few other areas that are worth looking at. Treating a patient with opioid use disorder is a major dilemma. Resistance is high, but change is necessary. We are not going to go back to the days of high-dose prescription opioids. Options are necessary, but they are limited. Boundaries are necessary and are often life-saving, but not welcomed. Your patient will question, why do I need boundaries now when I didn't in the past? Please be compassionate and stick to the boundaries. Do your best to not get distracted by the pain diagnosis. If we were to draw a flowchart of possible outcomes, this is what it might look like. There are 4 possible outcomes. First of all, you might be able to wean successfully. With some patients, the reduction of opioid dose will be successful. They will have tolerated the 10% reduction per month without a problem. These patients most likely do not have an opioid use disorder. Along with the successful weaning, these patients may need assistance with pain management classes, physical therapy, or the input of a dietitian or psychologist. Many patients will wean to a point of dysfunction, where they report they cannot tolerate the reduced opioid dose. At this point, you could continue to slowly wean with periods of plateauing, such as weaning for 10% per month for 3 months, then no weaning for a month or two. As you progress down this path, you will find the opioid use disorder will start to show itself as the dysfunction surfaces. If you reach an impasse and further weaning is necessary because of the patient's dose of opioids, but they are unable to tolerate the wean, then it may be time to consider transition to buprenorphine. Our experience at the addiction clinic where I work currently is that 85% of these patients do extremely well with a significant improvement in their life when placed on buprenorphine. Some of these patients would benefit from being part of a recovery program, although it may be difficult to find a program for patients with chronic pain and opioid use disorder. What do you do with the few patients who do not tolerate the transition to buprenorphine? Firstly, they may have to be continued on their current dose of opioids with pain management consultation involved. A more palatable plan may be referral to a methadone program for ongoing treatment. Please do not allow the frustration in dealing with this patient to cause you to discharge them from your practice. We do not want these patients to turn to their street available options. Final points to consider for the primary care provider is do not forget that you are dealing with a devastating disease. These patients are in a great deal of pain and turmoil. Be patient, be compassionate, and stick to your boundaries and plan as you listen to your patient. Treat the problem and not the pain complaint. This can be very difficult. Do not be distracted by the complaints of physical pain. It can easily lead down a path of endless tests and more confusion. Develop community boundaries. Meet as a group of primary care providers to determine the boundaries that will be placed in your community. We need to stand together as a medical community to be successful with this very difficult problem. To address this problem, we will need the necessary medical manpower. All primary care providers should have an X waiver to be able to prescribe buprenorphine. Stand together as a medical community. Meet to discuss cases. Work with your local addiction specialists and programs. To the addiction specialists, your primary care colleagues are struggling with a very difficult problem. They will need your help on occasion. Contact your primary care colleagues. Be available. Be ready to speak at their group meetings. Your experience and expertise is needed and will be appreciated. As difficult as it may be, it would be helpful if you, as an addiction specialist, would be willing to take on some of these difficult, very resistant patients. If we expect to address the problem of opioid use disorder in patients with a pain diagnosis, we will need to stand together as a community of addiction specialists and primary care. These patients are suffering, confused, and often feel betrayed. We do not want our patient community to lose trust in the medical community or seek care from the local heroin dealer. If we stand together, we can have a significant impact in the lives of patients suffering a terrible disease. For additional references and additional help, as well as additional videos, please contact the Fractured Resilience website. Thank you.